Hello, everyone. This is Dr. Siddharth Dambar here at Chicago Arthritis and Regenerative Medicine. Thank you for joining us in our webinar today. We're going to go ahead and get started now. I'll probably be talking for about 30 minutes, and if you have any questions, please type in your questions, and I will try to answer them as we go along. And just as a kind of FYI, after we're done today, you'll get a copy of this webinar as well if you wanted to replay or share with anyone else. And after we're done, if you have any questions, you can always email us, contact us via phone or via any of our social media sites as well. Okay, great. So let's get started. So today we're talking about regenerative medicine treatments. Specifically, we're talking, what you'll get from this webinar today is what are the non-surgical treatments that are useful for arthritis and tendonitis that do not require surgery. Talking a little bit more about prolotherapy and platelet-rich plasma, but we'll touch on bone marrow-derived stem cell treatments as well. We'll talk about what is legitimate and not legitimate in the field of regenerative medicine, how to choose the right regenerative medicine treatments and providers for your condition as well. And again, after we're done, if there's any questions, you can always contact us afterwards as well. So the big question is, what would you do if your pain was controlled or better controlled? How would your life improve? What exercises would you restart? And what activities with friends and family would you start to participate in again? I'm sorry, I'm just going to put this on hold for one moment. I will be right back. I just have to take care of one technical thing and I'll be right back. Sorry, hold on. Okay, great. Thank you everyone for your patience. Let's go ahead and continue here. So just a little bit about who I am. My name is Siddharth Dambar, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology and regenerative medicine, specialist in image-guided musculoskeletal injections. Been doing this since 2008, in regenerative medicine since 2008, part of the Regenix network, which is the largest network of physicians who are sharing ideas and IP when it comes to regenerative medicine. My own personal journey to regenerative medicine really starts with my own shoulder. I played tennis, sort of amateur competitive when I was a teenager. I never really had any problems. However, in the course of my medical training, I started to learn about musculoskeletal ultrasound. I noticed in my own shoulder that I had some chronic rotator cuff issues. Did not really become an issue until I got a little bit older. And it got me thinking about tendon and ligament injuries in a more dynamic manner, about what actually seems to help treatment and what doesn't. In some of that training, I ended up learning more about treatments like prolotherapy and platelet-rich plasma, and then eventually bone marrow stem cells. And then when it came to treating my own patients, starting to realize that traditional care for things like arthritis, tendonitis, back issues, they mask the pain, but you're really just waiting for surgery with traditional care, which is not the right way to treat people. And there's a lot of problems with this traditional care, including pain medications. They don't fix the problem. They have side effects. Traditional injections, things like steroid injections or nerve blocks and radiofrequency ablations, again, they help with pain, but they have side effects that are really not great for you long term. Surgery has its role in certain people at certain more advanced conditions, but it's higher risk. And if you can treat things without surgery, without accelerating the arthritis process, without causing more instability, you should try to do so. And for those of us that work in this regenerative medicine space, we really feel like that eventually 80% of the musculoskeletal conditions that we're currently treating with surgery will eventually be handled non-surgically. In the same way, in something like cardiology, where a few decades ago, most things would go to cardiac surgery, open cardiac surgery. Now, most of it is handled either through needle-based procedures or medications so that you don't need bigger surgeries. That is sort of the trend for most things in medicine. And the same thing will happen here as well. So in searching for better options, we need things that are lower risk and avoid side effects, address the actual source of the problem, which is instability and inflammation, actually improve the cause of the problem, and give you longer term improvement as well. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So in terms of regenerative medicine, essentially, this is the process of utilizing your body's own cells to treat arthritis, tendonitis, injuries, and back pain. If you think about how your body normally heals after an injury, take something small like a cut on your finger. A cut on your finger essentially repairs itself in the following way. You have platelets that first stop the bleeding. Those same platelets then release growth factors, which then stimulate your local mesenchymal stem cells, which then leads to more cells and tissue kind of being brought in to then progressively rebuild that tissue to heal from that injury. That works very well in tissue that has good blood supply, but in tissues that have poor blood supply, including tendons, cartilage, ligaments, disc labor, and menisci, all the musculoskeletal tissue, you don't tend to heal very well on your own. These are tissues that are hardy, but once they've been recurrently injured or damaged or too severely damaged, they tend not to heal very well on their own. So regenerative medicine is the process of taking those same cells and injecting them under high-level image guidance to coordinate that normal healing process. So why regenerative medicine? It treats the source of the problem. We'll talk a little bit about that, instability and inflammation. Safer than surgery, effective for most musculoskeletal conditions, and is certainly the future of how we'll be doing things. So again, how does regenerative medicine work? To begin with, when you look at the cells in a joint or tendon that have been chronically damaged, you have cells that are no longer functioning well. That means is that they're no longer pumping out the right proteins, the right enzymes. That's what leads to chronic inflammation. And so on a cellular level, we know that by re-injecting your own platelets or your own bone marrow cells, that you can help to optimize some of these cells that are no longer functional well. You can get them to start pumping out the right kind of cells, the right kind of proteins and enzymes so that you have less inflammation and a healthier joint. Number two, we can improve the strength and stability of the supporting ligaments, tendons, and other soft tissue structures. I'll talk about what prolotherapy is and how that works in a moment. This leads to reducing chronic inflammation. We can also treat some of the other supportive structures like the nerves and the muscles as well to overall improve the overall functional unit that is a joint that is arthritic. So very busy slide, but basically what makes a regenerative medicine expert is a lot. And it's important to recognize because you want to make sure you're seeing a physician that understands what they're doing and can treat things appropriately. And what you really need is the following. Number one, your physician should be a musculoskeletal expert. This may sound obvious, but the reality is that if you have a license to practice medicine, you can do a lot of different things. If your physician is treating somebody's high blood pressure in one room, somebody's runny nose in another room, their erectile dysfunction in another room, and then they come in to treat your knee, that's not really a musculoskeletal expert. That's someone who's touching on too many different things. The way medicine works is the more of an expert you are, generally the better you are at that modality. Number two, they should be a non-surgical musculoskeletal expert. A lot of our surgical colleagues, they are incredibly well trained for surgery. They don't get the same level of training for when it comes to some of these non-surgical treatments. One of that is that they need to be using high-level image guidance, ultrasound and x-rays to do all these procedures. That is a whole different sort of set of training to do this correctly. If you're injecting steroids, you don't really need to be close to the structure that you're injecting. There's just a general inflammation reduction. But if you're injecting your own cells, you have to be very down to the exact spot that's damaged. You have to be down to a sub-millimeter level to do this properly. The next thing is your physician should understand how to use inflammation to help you heal. Most people think of inflammation as like a bad thing, something to suppress. The thing is that that's your body's normal way of trying to heal after an injury. And so when you're doing things like steroid injections or chronic anti-inflammatory medications or ice after a procedure, you're actually limiting the effectiveness of some of these treatments. And so your physician should understand how to properly utilize inflammation. And then they should understand that the different types of biologic treatments that are involved. I see a lot of colleagues who use, they say that they're using platelet-rich plasma, but they're not really doing it correctly. Or you'll see that they claim to be using exosomes or different kinds of stem cells, and you look into it and you realize there's no living cells in some of those products. So sometimes the physician may not be as well educated on the topic as they should be, and they may be offering treatments that are not ideal for what you have. And the next part is you need to have a bespoke or personalized treatment plan as opposed to a generic one-size treatment plan. And what that means is if you walk into the office and the same treatment that the last 5 patients is the same one you're getting, and you are not the same person as those other 5 people, you're probably not getting a personalized plan. And that's critical because how you get a better result is through a personalized treatment plan. We'll talk a little bit about prolotherapy and how to treat instability in a little bit, but that is a very key part of this. I find that most of my colleagues don't understand this. That certainly was not something I was taught in medical school, something I was taught by colleagues as I sort of started my practice. And then they should be transparent about results and candidacy for treatment. Are you a poor, fair, or good candidate, and understand what that means in terms of results? They should follow your results long-term in that they shouldn't just be doing your procedure and you never see them again. And they should guide you through the process. People have questions, and it's important that your physician is an expert to help answer those questions. A couple basic questions that we frequently hear. Is this legal? Yes. There are very strict guidelines from the FDA. Those guidelines are you cannot utilize somebody else's living cells in you. Number 2 is that if cells are taken, they need to be processed and injected the same day. They cannot be saved for another time. And number 3, it has to be used in musculoskeletal tissues, not for other things. Another question here is, if I'm older, should I use someone else's cells? The answer is no. It sounds interesting. And the reality is, if we were all 20 years old, yes, we'd probably respond better to all treatments. But utilizing somebody else's cells brings other potential side effects. And the data out there shows that for most people, using your own cells is more than adequate to give you a good degree of relief and improvement. There's some exceptions to that, which we'll talk about later, but for the most part, there is no age limit for these kind of treatments. The one exceptions are hips, where if your age is more than 65, then your results may not be as good as if you're younger. Again, what sort of doctor does these treatments? I talked about what are the kind of things that your physician should be to be an expert. Those are very key. They should be all of those things. They should not just be 1 or 2 of those things. They really should be all of those things. Can these treatments help if you already had surgery? Depends on the type of surgery. If you've had, let's say, an arthroscopy, yes, it can still help. If you've had a joint replaced, you now have metal in the joint, so you can't really treat that. But if your pain, even in a joint that's been replaced, is still painful, well, your pain may be coming from a nerve, and that can still be treated. My general recommendations and rules for patients who need orthopedic surgery is try to keep your own anatomy as much as possible, if that's possible. Avoid surgeries that are only cutting out tissue and not trying to solve a problem. Most arthroscopies are just cutting out tissue. And always consider regenerative medicine treatment option if you've been recommended surgery to see if you may be an appropriate candidate. So we're going to talk about some key concepts here for regenerative medicine, stability and prolotherapy, orthobiologics, and interventional orthopedics. Stability is essential when it comes to the body. So in architecture, there's this concept of tensegrity, which means that if you take individual units that are weak on their own, if you put them in close approximation and then compress them, you have a structure that is much stronger. So in biology or in medicine, that's called biotensegrity. So prolotherapy is the process where we inject your own cells or other concentration of other fluids into the soft tissue supportive structures around a joint to help strengthen and stabilize that all over time. The key to understand is that you need to treat all the layers in depth that are affected. There is a slow progressive strengthening over time, and usually multiple treatments are needed if you're doing prolotherapy, and that you get a longer lasting result than if you would like a steroid injection. Steroid injection will give you quick relief, but then kind of wear down. If you can help to improve stability, you get a longer lasting result as well. So prolotherapy is both a concept and a treatment on its own. So as a concept, it's this concept of strengthening the ligaments and soft tissue structures to optimize a joint functional unit. That's been around for decades, actually. If you look at going back to the 1950s, there are physicians utilizing dextrose or sugar for prolotherapy treatments, and they did that for literally a few decades. Starting in the mid-1990s, you started to see physicians start to use things like platelets and bone marrow for musculoskeletal conditions. Our veterinarian colleagues were doing this at an earlier stage in the mid-90s, but as time went on, you started to see people utilizing your own cells for treating treating joint and tendon injuries as well. If you're treating those other soft tissue structures with your own cells, that is still a form of prolotherapy. So when it comes to treatment, prolotherapy is a concept. There's the basic prolotherapy concept or treatment where you're using dextrose or sugar water. That's the original regenerative medicine treatment. And that works by causing some slight bit of inflammation, which triggers a normal healing process in that individual. An advanced version of that is now utilizing your own cells, your own blood platelets, and your own bone marrow stem cells. So when you think about this treatment spectrum, generally speaking, this is how it works. Dextrose prolotherapy, generally because it's milder and slower acting, will generally take monthly treatments for 3 to 6 treatments. While platelets, or PRP, platelet-rich plasma, is stronger than that. Generally, if you need a second treatment, generally you're talking about doing that at the 6 to 12-month mark. And if you're using a treatment that's stronger than that, which is your own bone marrow-derived stem cells, generally you're repeating treatment every 2 to 5 years if needed. So this is a case study of how prolotherapy works. So a 71-year-old man, he's had a prior laminectomy surgery, prior lower back surgery, ×2, still having pain, very common in folks with lower back pain. In his case, we ended up treating several different areas. We ended up treating not only the epidural space where the nerves come out, the facet joints, we treated the ligaments and the muscles, really comprehensively treating things in a prolotherapy style fashion. He originally had platelets, PRP treatment, which gave him about 30% pain relief after a few months. We ended up escalating to utilizing his own bone marrow stem cell treatment, and he's now significantly better at around 75% improvement for a few years now and doing well. So this next concept, orthobiologics, these are the cells and tissues from yourself that we utilize to inject into orthopedic tissue. As I mentioned, they utilize that normal healing process, and I strongly recommend utilizing your own cells. That may sound a little bit futuresque, but the reality is in the United States, you can only utilize your own living cells. If you're using somebody else's cells, which I'll mention in a moment, they have to be dead. You can go to other parts of the world and get other people's cells injected. You just have to be aware of potential theoretical risks associated with that. Also keep in mind that when you look at the data for these treatments, the overwhelming amount of this data is in using your own cells. And that's what I would recommend in your case as well. So platelets or platelet-rich plasma is really the first line of orthobiologics. And again, platelets are important because they start the normal healing process. They utilize inflammation to start tissue repair, and they work by stimulating your own local stem cells. So there's different types of platelet preparations. So platelet-rich plasma is basically where we take a blood draw from you, centrifuge it, and then concentrate it. If you look at the picture on the right of the screen, you'll see 2 different types of platelet preparations. You have the one on the right that has a lot of red blood cells. It's very red colored. That is more inflammatory and will tend to cause more discomfort. Then you have the concentration of platelets on the left that has more of an amber or yellow color. that has taken out the red blood cells, and now we're just injecting platelets and a little bit of plasma. So that is less inflammatory, and that's what we recommend for utilizing for joints and tendons. The red one, a little bit more inflammatory, works probably a little bit better for muscles, but the one on the left, the amber colored one, is the one that you should be getting if you're having your arthritis or tendonitis treated. If you're getting the one on the right, you may not be getting an ideal treatment. So that is one type of platelet preparation. The other one is called platelet lysate. That's where we take those same platelets, crack them open, and just take the growth factors. We utilize that if we're injecting around the nerve. The reason why is it's less inflammatory and healthy for the nerve as well. So there's different types of platelets, and it's important that you get a personalized treatment approach as opposed to the same treatment that the last 20 patients got before you walked into the office. So this is an example of a 45-year-old man, cyclist, originally was referred to me by a sports medicine physician because he had persistent patellar tendonitis. The ultrasound image on the right essentially shows a tendon that has a lot of tendinopathy changes. The white colored line, the very highly colored white line is the patella or your kneecap. So in his case, we treated him with platelet-rich plasma 2 times. Picture on the right is a needle going into the patellar tendon. We do this under ultrasound guidance because that's how we make sure we're hitting the exact right structure. He had 2 treatments, returned to his full activity and doing great. Saw him again 3 years later. Now his other leg had a problem. He had a hamstring tear or hamstring tendonitis. Treated that with platelets, and again, pain resolved, back to activity. What I like about this case is, number one, you see how platelets can be utilized for a few different things, tendons as well as joints. And the other aspect to this is you see how ultrasound is key and how repeat treatments can be useful as well. The next type of orthobiologic to understand are your own mesenchymal stem cells. These are the main cells that drive tissue repair after an injury. Again, utilize your own cells, not somebody else's. Understand in the United States, the only type of living stem cell treatment you're allowed to use are your own bone marrow-derived cells. Fat cells used to be used in this country, found to be illegal currently because there's an enzyme that you use to dislodge the cells from the fat, and the FDA has concerns about that, about the safety of that. You still see that used in other parts of the world, but not really utilized in the US any longer. You can still use fat or adipose if you're using for structural support. For example, let's say you have a tendon injury or a ligament injury. If you want to inject not only your own living cells, but you want to put some structural support from the adipose, you can do that as well. You may hear about amniotic and umbilical cord cells. That was a little bit more popular in the last 5 years, a lot less popular because people have been billing that to insurance and they got into trouble for that. Understand that there's no living cells in those if they're sold in this country. And so you're not really getting a stem cell treatment, you're getting more of a growth factor treatment. You may hear in other countries where people go and get umbilical cord cells injected IV as well. Understand in the US that's illegal. There's really no proven benefit for orthopedic conditions. It may help with general inflammation, but really I would try to be cautious with that as well. You know, when it comes to how do you decide which one of these treatments to utilize, it's a few different things. Number one is, what's the severity of your issue? Do you need something that needs a stronger cell type versus a less strong cell type? If you're getting a milder treatment, understand that generally multiple treatments are needed. If you're getting a stronger treatment, less treatments are needed. What are your medical contraindications, right? You know, we'll see patients where, you know, maybe they're on blood thinners, hard for them to get off the blood thinners. Well, doing a bone marrow is unsafe in that case. Or, you know, maybe someone's had a history of cancer in the last year. Need to be careful about what kind of cells you use there. Maybe prolotherapy is a better option. So there's medical contraindications. There's obviously personal preference as well. Keep in mind also, sometimes we may do like a bone marrow treatment and maybe it's 2 years later and you know, someone's doing well, but they're having a little bit of a retraction of their benefit. At that time, maybe we just do a platelet booster treatment rather than like a full bone marrow treatment again. And then of course, cost. You know, cost is a key part of this as well. There are insurances that cover this, but it's still a small percentage of our patients that we see. And so cost can make a difference in terms of which treatment you can afford as well, of course. In terms of outcomes with stem cells, we can definitely improve pain and function even if you have advanced cases. So can we improve how your x-rays and MRI images look though? If you've got advanced arthritis, we can't get that to look like what you were 20, 30 years ago. It's unrealistic. On the other hand, if you have a tendon tear or ligament tear and it's still within reason, we can actually get that to look normal. I'll show some pictures of that. If you've got chronic swelling in a joint, we can reverse that. If you've got damage in the bone, which is called avascular necrosis, if we're catching that at an earlier stage, we can reverse that. If it's a later stage, you can't really reverse that. Can we treat what's called bone-on-bone arthritis? The term bone-on-bone arthritis is really the most non-medical jargon there is, but you'll hear physicians say that. So it depends. But understand that arthritis is not just what your x-ray shows. It's a biologic condition, and so that is treatable with orthobiologic treatments. If your range of motion and function are still fairly intact, you can still get a very good outcome with treatment. The caveats to this would be if you've got more advanced arthritis in the hips, that is hard. That generally should go to surgery. Also keep in mind, even if you have more advanced arthritis, it's not about reversing how your imaging looks, not possible at that stage. It's more about improving pain and function. Okay, I see some questions coming in. I am not ignoring those. I'll get to these in a moment. Actually, I'll kind of answer this one. Someone's asking about using ultrasound versus x-ray. You use the right tool for the right issue. So if you're treating the spine, you're generally using x-ray guidance. But there are other things, maybe knees or shoulders, where you're using a little bit more ultrasound. Sometimes we're using both of them. It depends on what we're treating. This is a knee case that I'm showing up here on the screen right now, where this is actually, the question comes up, can you actually treat tendon and ligament tears? And the answer is, if it's a partial thickness tear, absolutely. If it's a full thickness tear, in some cases, yes. Some cases that should go to surgery. So this is a 20-year-old man. He's a butcher. He had an ACL tear playing recreational volleyball. I saw him shortly after his injury. We ended up treating him with his own bone marrow aspirate concentrate treatment. 3 months later, doing great in terms of pain, restarting dynamic activity. What's really exciting is some of his imaging results. So this image on the right is x-ray guidance injecting his ACL. You cannot do this blindly, meaning just palpating the knee and trying to inject it. You really cannot do this with ultrasound either. You can do this properly under x-ray guidance. And so I don't know if my cursor is showing up, but essentially there's a needle, and what you see highlighted in the middle is the ACL. And you can do that under x-ray guidance. So what's exciting here is also his imaging response. So we generally try to guide people that it's more about improving pain and function, but some things do dramatically improve on imaging as well. When you look at his MRI images, again, I'm not sure if you can see my cursor, but his MRI on the left is showing an ACL that's very hazy looking. It's at a minimum a partial tear, complex partial tear, possibly a full thickness tear. His radiologist has read this as likely a full thickness tear without retraction, meaning that they're still relatively lined up, the edges of the ligament. It's not like they're pulled out to either end of the bone. His images, his MRI images 3 months after treatment has now been read as essentially a normal ACL, very linear and intact looking. No longer do you have that haziness. No longer do you have a ligament that's sort of kinked at the bottom. It's completely very nice looking. There's a little bit of fluid still around it. It's still healing, but looks dramatically better than what it was before. Exciting because that is how, that's not only improving his pain and function, that is literally healing his problem as well. This is I hope this one came up. This is a case study for a general contractor, 57-year-old, for his rotator cuff tear, utilizing his own bone marrow stem cells and platelets. Pictures on the left, these are his ultrasound images. He has essentially, the two images here on the left, he essentially has a hole in the rotator cuff, right? This is a full thickness tear. Tendon is not fully retracted, but it's torn for sure, right? 3 months later, again, he's doing great. And here's his tendon where you previously had the hole, and now it's been filled in, right? That is a great result. This treatment was done about 7-8 years ago. I saw him again this past year as we ended up giving him a booster treatment to keep him going. And he's actually now a few months out from that and doing wonderful as well. So the question about shouldn't we be using x-rays or radiography? When it comes to injecting the spine, 100% yes, that's what I would recommend. It's just utilizing the right tool for the right issue. Interventional orthopedics. So this is the next concept where you're using image guidance to treat orthopedic injuries. This is a picture of a rotator cuff tear that's being treated with platelets. The needle that you see coming in from the right, that's injecting into the rotator cuff. There's a small little gap that you see where the tip of the needle is. That is a very zoomed in view, all right? So that is literally injecting at a 1 millimeter by 1 millimeter level. You cannot do this just blindly. You have to do this under ultrasound guidance for this. This is an example of where another shoulder case, where maybe you're utilizing ultrasound for the rotator cuff, and now here we're using ultrasound to inject the joint and the labrum as well. What's nice about this is on this X-ray image, the needle is in the joint. You see a little bit of contrast in the joint to confirm we're directly in the joint itself. And there's a little triangular structure here. That's a labrum. It's a very small thing, very, very tiny issue to hit, but we can confirm we're hitting that as well by utilizing X-ray guidance here as well. So using whatever tools that we require is the key here. Again, these are images of the knee. On the left is using ultrasound guidance to inject the patellar tendon. On the right is using X-ray guidance to inject the ACL. It's another case study of a 41-year-old man, left ankle pain. He's a chef, professional chef. He's on his feet for 12 to 14 hours per day. So in his left ankle, he's got progressive arthritis, inflammation, even early avascular necrosis, which means that the bone is starting to die off. So the image on the left, you see a little bit of fluid, narrowing of the joint, and you have this white stuff in the bone as well. If we do nothing about this, this will eventually erode the bone and damage the cartilage and lead to much worse osteoarthritis. In his case, we injected his own bone marrow cells into the joint, the ligaments, and into the bone itself. Again, three months later, his images, he still has his wear and tear arthritis, but the inflammation is gone and the damage in the bone has reversed as well. So exciting, because we are literally now preventing his condition from progressing. He's a few years out now and continues to do very well and continues to work as a chef. So regenerative medicine treatments offer safe and effective solutions for your pain. Okay, good question. Somebody asking, if we're doing a treatment, are we sedating you? It's not routine to sedate people. It's an option for sure. If you're getting sedation, there's different levels. There's anything from just taking a Valium. There's some stuff that's a little bit stronger than a Valium, and then there's bringing the anesthesiologist and give you an IV sedation as well. So all that is on the table if needed. At a minimum, if you don't get any of those, you'll at least get numbing medication as we're doing this, injecting underneath the skin and then doing the injection. But if you need something stronger than that, that's always available. Somebody asking about a neck brace after PRP to heal the cervical areas. You have to be careful with neck bracing. If you're utilizing it, you should be utilizing it short term, meaning only for a few days up to a week. It's more about letting the body normally heal after treatment and then making sure that the muscles stay strong as well. There's always a potential risk after, if you're using a neck brace too often, that the muscles start to get reliant on it, start to get weaker over time. And then just to kind of point out, well, I will treat the lumbar spine. If you're treating the cervical spine at the neck, I'll end up referring to a colleague of mine as well. It's a good question. How do we know we're getting the highest concentration of platelets for patients healing? It's a great question. So the way that we do our lab prep, we have a full degree of flexibility in terms of getting the concentration of platelets that we want. So there's some basic sort of calculations that you do in advance to figure out how many tubes of blood you need to take out. But the higher concentration that you need, the more blood you take out. And the more areas that you need to treat, the more blood you need to take out. So you make that calculation in advance. And so as an example, if you need to treat a joint, you're using 14 to 20 times normal concentration of platelets. If you're treating a tendon, you're using more like 7 times concentration. So that's how we base how much we're taking out. Somebody asking, how long is rest needed after PRP injection for a hamstring issue? Good question. So in general, after treatment, you will have more inflammation. And more inflammation means the area will be swollen and uncomfortable. So if the tendon is intact, it's not that you cannot do activity afterwards. It's just that you'll be sore if you do too much activity. And so what we generally recommend, it depends on what activity. If you are, let's say, at work, you do a lot of walking, heavy lifting, we'd recommend limiting that for a week after treatment. If you are, let's say, a runner, we'd recommend backing off for about 2 weeks afterwards. And then when you reincorporate, starting at a low level and then slowly, progressively going up with some guidance from physical therapy as well. If your tendon tear is a little bit more than that, you may need to be shut down for a little bit longer than that. So it just depends on degree of injury as well as what your baseline activity level is. Again, any other questions after we're done today, you can go to chicagoarthritis.com. Is this too good to be true? There's evidence for these treatments going back to Philip Hernigue, who's an orthopedic surgeon from France back in the 1990s. Regenix, the network, has data since 2005. This is definitely a rapidly developing field. It's absolutely not new. My own personal experience goes back to 2008. There's right ways and wrong ways. Your expectation should be grounded in reality. I can tell you that I had colleagues who 10 years ago said they didn't believe in this at all. Now they'll tell patients they think it may work. They're not sure, but it won't hurt. And the reality is, if you're in the field, you're in it daily, and you understand the data, you know what is legitimate, when it can be very helpful, and maybe when it's not the right treatment. But I think for some of our colleagues who are a little bit newer, who are not quite as aware, they see some potential. They're not exactly sure, but for those of us that are in the field who are doing this every day, when you know the data that's available, I think you know what is realistic and how to do it correctly to maximize your results. How long do results last? Philip Hernigue has data that goes over 20 years. Regenix has data that goes over 10 years. I still tell people for a chronic condition, have realistic expectations. What that means is, so for something like a bone marrow treatment, you're going to get benefit for about 5 years, and some people more than that. You may need a platelet booster at some point. That might be at the 5-year mark, that might be at the 2-year mark. It's varied from person to person. If you're doing platelet-rich plasma treatment, again, expect that you'll get an improvement for at least a couple years, 2 years. There's some people where they may need treatment at the year and a half mark. But in general, there's that slow progressive improvement. If it's prolotherapy, which is milder, if you're using dextrose only, you'll need a series of treatments, 3 to 6 upfront, and you should do well for at least a few years with that. The best ways to maintain your results after treatment: improve your biomechanics, improve your posture, improve your strengthening, use the appropriate joint supplements for pain and inflammation. Understand that repeat treatment is additive to initial treatment. Steroid treatment gives you improvement immediately, then back down to baseline. These treatments, there's a slow improvement over months. After some time, you'll end up plateauing. You'll stay at that plateau longer term. If you start to dip down, if you get a second treatment, you're now building from the higher baseline level, and now you're kind of escalating beyond that as well. And then maintain ideal body weight as much as possible. It helps to reduce stress on lower back and legs, improves your metabolic health as well. This is an important enough issue where we actually have our own physician-assisted weight loss program as well now, just to help out our patients who need that assistance also. As I mentioned a lot when it comes to how can you be a regenerative medicine expert? Basic takeaway is it takes a lot, but that's the right way to treat people, and that's how things that's how you get the best response in medicine. If you are fully committed and fully an expert in what you're doing. So a little bit about us, about how we do things here at Chicago Arthritis. We're focused on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain, evaluating for inflammation, instability, asymmetry, neuromuscular issues, correcting with lower risk interventions if possible, then escalating as needed. That goes for everything that we do. If we are talking about a regenerative medicine treatment, trying to utilize the best products that are appropriate for you, plan that is specifically tailored for your condition and your needs, and delivering those treatments using the highest level of image guidance possible. interested in getting evaluated, you can reach us at chicagoarthritis.com. You can email us at admin@chicagoarthritis. You can call us. You can contact us versus our social sites. After we are done today, you will get an email with a link for replay if interested. And of course, you can contact us at any time if you have any other questions. Okay, I see a few more questions. Let me just try to answer these before we're done. Somebody asking about prolotherapy or PRP on a bone-on-bone in a hip. Hips are very hard, all right, if you're at a more advanced stage. The way that I'd recommend thinking about it is if you still have, like if your hip can still swing in and out of range of motion pretty well, then you should consider using your own bone marrow cells for that. If it's limited, it's going to be hard. You should be thinking about surgery. The exception to that would be if your hip pain is actually not coming from the hip, but it's coming from the SI joint or the back. Example that I have is I have a patient who had bad hip arthritis, thought his pain was coming from the hip, actually had a hip replacement surgery, still had hip pain. We ended up treating his SI joint with his own platelets, and he's done great with that. It turned out his pain was actually coming from his SI joint. So that's the one caveat to that. But in general, for advanced hip arthritis, you should be thinking about surgery. Somebody asking about another cervical spine issue. Again, I think when it comes to treating things like the alar ligament, the cervical spine, I generally will refer to my colleagues who are a bit more experienced in treating cervical spines. When it comes to treating the neck, you really want someone who's not doing this once or twice per month. You want someone who's doing this multiple times per week. Just the neck is a little bit of a different beast. There's a lot less people can treat that. And if you need a referral for that, we can always give you names for that as well. Okay, wonderful. Before we end today, any other questions for me today, guys? Let me just check to see if there's any questions as we're also streaming live on Facebook, IG, and YouTube. Okay, wonderful. Well, listen, everyone, thank you for your time today. If we can be of additional assistance in terms of evaluation, treatment, or with questions, please let us know. Again, somebody asking about arthritis in the ankle. Yes, again, needs to be evaluated, but yes, we can treat that as well. And until, wow, questions just keep on jumping in. Somebody asking about seems to be muscular. Again, depends, right? Are we talking muscle strain, muscle tear? It's more of a nerve issue affecting the nerve, so it depends, but muscles can definitely be treated as well. But thank you, everyone, for your time today. Until we connect again, I hope everyone stays healthy and active, and hope everyone lives well. Bye-bye.